Let's talk about the evaluation of dysphagia. So first step is determination of the type of dysphagia. And we do that by taking a simple history. If the patient has difficulty initiating the swallowing, or if the patient has choking or aspiration, then this is probably an oropharyngeal dysphagia. And if the patient can initiate the swallowing, but the food sticks after the swallowing, then this is probably an esophageal dysphagia. And after setting the types, we have to look for the features of the differential diagnosis. So if the patient has an oropharyngeal dysphagia, the differential diagnosis could be neurological disease, muscular disease, or structural disease. The common neurological diseases that are associated with oropharyngeal dysphagia are stroke, Parkinson's disease, motor neuron disease such as amyotrophic lateral sclerosis. The muscle diseases that can cause oropharyngeal dysphagia are polymyositis, myasthenia gravis, and muscular dystrophy. The structural causes may be Schenker-David-Colum web, such as associated with IDA, and thyroid diseases. So those are the differentials for oropharyngeal dysphagia. If the patient has esophageal dysphagia, then the differential diagnosis would be structural disease or some functional causes. The common structural diseases are carcinoma of esophagus, esophageal stricture, and esophagitis. The functional causes include achalasia cardia and scleroderma. And the second step would be a brief history and clinical exam to find out the underlying cause. So if the patient has esophageal dysphagia, our history would include any past history of diseases such as stroke, neurological disease, or muscular disease. If there is any local symptoms, we have to take this history. And after the history, we have to locally examine the patient's head and neck, and we have to also examine the nervous system. If the patient has esophageal dysphagia, sorry, which was oropharyngeal, if the patient has esophageal dysphagia, we have to take the history of type of dysphagia. If it's only to solid and if there is weight loss, then that is suggestive of cancer. If the patient has dysphagia to both solids and liquids, more likely to be achalasia. So we have to do the general exam in this patient to look for cachexia, anemia, and lymphadenopathy, which are evidences of carcinoma. And the third step would be investigations. If the patient has oropharyngeal dysphagia, our investigations would be a video fluoroscopic swallow assessment, along with some investigations to assess for any underlying causes, such as CT scan of the head, neck, laryngoscopy, and MRI of the brain. In case of esophageal dysphagia, we have to do an endoscopy and biopsy, and we may have to do an esophageal manometry, especially if we are thinking about achalasia as the underlying cause.